So thank you, Theo. We've learned a lot about our approach to multi-morbidity during the previous presentation, and questions came up already regarding some findings around our user perception towards C3-Cloud. So this question, as well as questions around the evaluation of C3-Cloud system, the region's plans to make the services sustainable, and our business and exploitation plans will be addressed in this last session over the next month, over the next hour. So in this talk, I will present insights on our evaluation of the C3-Cloud solutions. Now, one of the challenges that we aimed to tackle with C3-Cloud is that care planning for multimorbid patients is complex, and it is more complex for patients with multiple chronic conditions than it is for patients with just one condition. Common fallbacks include time-consuming care planning when considering the multiple chronic conditions at once. Time is spent on collaboration with the multidisciplinary team to check up on test results or to arrange follow-up consultations. And some examinations or consultations may even be duplicated, or the medication plan may be not well aligned to different conditions. Also, the patients and their informal caregiver may not have the resources at hand to be easily informed about the patient's conditions, the goal of their care, and what activities they should follow to reach these goals. So a solution to these challenges could be a C3-Cloud platform that is widely accepted to both patients and their multidisciplinary care team, that is useful for their self-management and professional care planning, and that should potentially also save healthcare resources such as time or treatment costs. To determine if C3-Cloud was able to reach up to these expectations, we developed a research protocol, and altogether we evaluated this user-centered design, the user experience, the acceptance and usefulness of the C3-Cloud system after thorough testing. And for that, we defined our four testing and evaluation phases. So in the first phase, early in the project, we tested user-centered design using mock-ups and discussion groups. Also, clinical users tested if the system complied with their clinical and technical requirements. In phase 2, we tested the integration of all C3-Cloud components and the user experience with a heuristic evaluation, early usability tests, and a user satisfaction survey. In phase 3, we tested the fully deployed solutions with users during the technology trial in 3 regions. We surveyed the acceptance, evaluated user training material, and evaluated the user satisfaction with the C3-Cloud platforms. Phase 4 was performed in the most recent months. It involved analyzing C3-Cloud usage patterns as well as developing impact scenarios for the situation if C3-Cloud were used at scale. For that, we use budget impact analysis and our assist cost-benefit analysis method to model the impact and to sketch scale-up scenarios. So the hope was that C3-Cloud is accepted and used by all user groups as a solution that is effective in reducing the workload for healthcare professionals, that improves patient self-management, and that reduces healthcare resource consumption. So during the early tests from phase 1 and 2, we asked 25 test users for their overall reactions to C3-Cloud. And what we learned is that users found the solution very promising already during this early development phase. They believed that the suggested care plan goals and activities were meaningful. So that's coming from the CDS and from the clinical decision support. And the operation on the platforms were intuitive. Doubts were raised if the group of elderly patients or older patients that were targeted would be in a position to work well with the technology, or if it was not the case that they lacked IT literacy. After these first tests, feedback was used for further development, and that was followed by deploying the C3-Cloud components in our 3 pilot sites and by carrying out our technology trial from November 2019 to April 2020. In 3 European regions, and that was Sweden, the UK, and Spain, so region Jämtland Härjedalen, South Warwickshire, and Basque Country. And in total, we recruited 125 healthcare professionals and 230 patients to the technology trial. So we've had a number of challenges with that technology trial. Firstly, we experienced several months delay in finalizing the development and deployment of C3-Cloud in the pilot sites. Why was that? Well, through the early testing activities, we learned a lot about the pitfalls and potential improvements of the platform, and it was crucial for all clinical partners that the software that we deliver was safe to use. And as a result, our pilot sites were convinced that C3-Cloud was a trustworthy and reliable system, and that was seamlessly integrated within their IT environment, and it was safe to use. However, the pitfall was that we had some delay. Number two was patient recruitment. Patient recruitment, we've seen that approximately 70% of the patients were lost to recruitment from the outset. And in response, we added a few more patients, or actually quite a bunch of more patients, to the pool of patients that we approached for recruitment. A decision was made early in the project to include patients with mild and moderate conditions only for this technology trial, and that limited the number of patients eligible for inclusion. So we decided to decrease thus the minimum age to start from 55. And efforts were made to provide simple and rich information to motivate patients to consent for participation. And we believe that the richness of this information available may have led patients to overestimate the level of input that was required from them, and that may have been a downturner for their participation. Thirdly, the COVID-19 pandemic, we've heard about it earlier. It struck just during the trial at a time when most patients and healthcare professionals had just overcome an initial time of adaptation to the C3-Cloud system. So starting from February 2020, usage frequency and the duration of that usage from our users that they spent on the system went down dramatically, as clinical staff was called to provide frontline services rather than spending their time and resources on the C3-Cloud research project. In consequence, C3-Cloud patients may have felt left alone and less well cared for. Finally, we've had a low evaluation survey return rate from patients and healthcare professionals. A general reminder was sent to all patients in the pilot sites where this was considered appropriate. However, ethics boards required us to set up the evaluation completely anonymous, and that did not enable us to send targeted reminders. So in summary, challenges included recruitment issues, the limited trial duration, the COVID-19 pandemic, and little survey returns. And consequently, our user experience with the C3-Cloud platforms was short and compromised. We have a limited databases for the evaluation, and the determination of significant resource use differences when comparing control patients with the C3-Cloud patients was difficult. Now, despite these limited databases, we do have results that we can share. And first of all, a rich set of training material and manuals was developed during the project. Users described the core training material overall as trustworthy and easy to understand. Given the volume of user training material and supporting documents, it could have been expected that some users wished it would have been more concise. So this is a learning for future developments of the C3-Cloud system. The benefit being that there's now a rich resource to learn from for future tests, for future training sessions and deployment activities. Now moving to our findings around user acceptance and their experience and the usefulness of the system. So I'm just bringing up some statements here that we've seen over the surveys. The analysis of the survey shows that healthcare professionals indicated the platforms were generally rather easy to become skillful at. They consider them useful for their job, and the platforms fit well with the way they work and the services they provide on a daily basis. Our surveys also show that the patients were slightly positive on whether to use the patient empowerment platform in the future, while they indicated that it was rather not worth the effort involved in using it during the trial. So this shows that patients do see the potential of the C3-Cloud system, yet they could not be fully convinced of its use just during the trial. That finding was slightly different for healthcare professionals who wanted to use C3-Cloud in the future, and they believed that it was also worth the effort involved in using it. The responses, or these responses, show the potential of the C3-Cloud system and that it can be useful and a powerful system to improve patient care. We've also received some rather retained ratings given by our users. Healthcare professionals do rather not believe that C3-Cloud will enhance their productivity just yet, and they could not put the system to full use during this trial. Now, decreased productivity is detrimental to what C3-Cloud envisaged for healthcare professionals, and it should be carefully reinvestigated in the follow-up trial whether these statements hold or if they originalize in the shortened trial period and the COVID-19 situation where a high workload and burden on the professional staff was prevalent. And the latter may have clearly turned healthcare professionals' perception to negative opinions on the professional C3-Cloud platform. Moving away from the surveys and taking a closer look on the impact modeling, a discrete event simulation model was used to represent mathematically the natural history of C3-Cloud patients' health conditions. This allowed to perform a budget impact analysis to generate economic healthcare resource consumption models for the following years. So once the trial was completed, we performed a statistical analysis to define significant differences in healthcare resource use between C3-Cloud patients on the one side and a control cohort on the other side. The differences were projected over a time horizon of 7 years using discrete dimension simulation model. And this projection in combination with unit costs helped us to model monthly cost per patient over the next 7 years. So the descriptive analysis showed significant differences for resource use, including primary care consultations, where we found significant reductions for consultations with GPs and nurses at the care center and for nurses during home visits. We've seen significant increments for telephone consultations between nurses and patients, and we've seen significant reduction in the number of patients with any emergency visit. Now, the assist cost benefit method was the last evaluation method that we applied in the phase 4 of this evaluation. The aim was to sketch economic scale-up scenarios for the pilot sites under using a cost benefit analysis. In this assist tool, we take a systemic perspective on the service system, including the stakeholders that are actively involved or passively affected from the service implementation. So here we see that patients and informal caregivers have their value case, organizations need a business case, involved professional staff has tasks, for instance, in the C3-Cloud services. The hospital's accident emergency unit experiences less visits, so they were passively affected. Payers, for instance, the Ministry of Health, insurances, or reimbursers covering care costs may have to reimburse some additional costs, but they also may benefit from cost savings due to fewer clinical and care consultations. Now, what may be a benefit to one stakeholder may be a cost to another group, and the assist analysis exposes these value shifts for different stakeholders. So we identified relevant positive and negative cost benefit impact indicators along categories. So that's financial impacts, resource use impacts, and intangible impacts. To give you some cost examples we included in the assist analysis, we see here, for instance, that C3-Cloud generated financial costs through the system development. Also, we see fewer GP consultations may be considered a cost for primary care organizations, depending on the reimbursement system. Redeployed resources include, for instance, time that professionals spend on their training to use C3-Cloud. A few benefits that we determined include, for instance, time that can be liberated during GP consultations or fewer nurses' home visits. Like on the last slide that you've seen, you see here also the fewer GP consultations, which is listed then both as a cost and as a benefit. This is based on the way we set up the analysis, and it illustrates a typical benefit shift that may occur. So fewer GP consultations may be a cost to primary care organizations, but a benefit to the institution that reimburses such consultations. We also see that travel time liberated by not traveling between the patient home and the care centers, and the overall satisfaction with the service, which is an intangible benefit that we monetize in the assist tool. Now, modeling such costs and benefits over time for reaching the implant here as an example, we can see how the aggregated costs and benefits translate into a cumulative net benefit over time. The curve is flat in the first 4 years, and the interpretation is that during this time, there will be still more patients and healthcare professionals added to the system, so added to using C3-Cloud, because not everybody will use it right away. And therefore, training and devices will still be needed, and these will be a C3-Cloud implementation cost. As soon as fewer patients, as soon as we reach patient saturation, so all those patients that can benefit from the service have been included already, and as soon as then fewer patients and healthcare professionals are added to the C3-Cloud service, the implementation costs will decrease, and then the systemic operational benefits will be larger than its costs. These include specifically time saved for primary care center and hospital staff, as well as monthly savings for the payer of healthcare services. And the latter saving is mainly based on the fewer GP visits and nurse consultations, as well as fewer accident and emergency unit visits. The 3 regions that we've considered vary regarding their overall cumulative socioeconomic return figures for the different stakeholder groups and also for their systemic socioeconomic return. Interestingly, the general direction has shown similar in all 3 pilot sites. Patients and their informal caregivers have an intermediate perception of the system, and their costs and benefits are rather equaling out. The healthcare professionals have a rather large negative socioeconomic return. However, this translates only into marginal costs in absolute euro terms, euro numbers. Healthcare organizations are the losers in terms of socioeconomic return and then have a negative net benefit. However, this is explainable largely as under current assumptions, they pay for training time on C3-Cloud, medical sensor devices for patient self-measurements, and they have foregone income, for instance, from the avoided GP and nurse consultations. So it can be debated if this is indeed a foregone income for them, as this is largely dependent on the reimbursement schemes given in the pilot regions. Also, reduction in GP and nurse consultations will in effect liberate their time, which they could spend to provide better quality care. A secondary effect could thus be increased healthcare professional work satisfaction and patients that feel better cared for. So if we had a reimbursement system where fewer consultations would not reduce reimbursements for the healthcare providers, their overall socio-economic return could indeed look much more positive. The great winner under our model, and under the given assumptions will be the payers, the reimbursers that cover costs for general healthcare provision, be that the Ministry of Health, Health Insurance, or the NHS. So the payers have saved large amounts of money with a highly positive socio-economic return ranging from 350% in South Warwickshire to 1,100% in Region Jämtland. So what have we learned? Generally, the evaluation results could benefit from a larger databases to improve the validity and reliability. That relates to extending the duration of the trial at a time when clinics are not overloaded, so not COVID-19, and including also patients with severe conditions and some clinical parameters in the evaluation. That being said, we see that C3-Cloud is perceived generally promising. The given circumstances have limited the user's capacity to enjoy C3-Cloud to its full potential. There's cautious acceptance of the system among patients and slight acceptance among healthcare professionals. However, a positive valuation of C3-Cloud may have been compromised due to the technology trial limitations that were mentioned earlier. Patients' satisfaction with C3-Cloud could be increased if the MDT, so the multidisciplinary team, were fully dedicated and involved patients more. C3-Cloud is a journey that healthcare professionals and care managers and healthcare provider organizations would want to tread. To understand if the socio-economic return could not be more positive for these organizations, one should consider the reimbursement systems in more depth. That can help to define benefit shifts across organizations even better. And under the current assumptions, healthcare organizations will liberate a lot of their time that is spent on redundant multidisciplinary team collaboration and longer care planning otherwise. Healthcare payers have the largest savings in monetary terms due to the avoided practitioner and nurse consultations. And the operational benefits are larger than the implementation costs. Thus, once fewer users are added to the system, the time to break even is approached, but that takes a few years. So this presentation gave a selective overview on the evaluation of the C3-Cloud technology trial. If you're interested in a much more detailed 400 pages exploration of our findings, I can only recommend you check back on the C3-Cloud website in a couple of months when this document will be published. Thank you very much.